Welcome this evening to a very important discussion in relationship to polio. All of the people here tonight, I'm sure, are aware of the fact that there's been a polio incident, and I want to thank Leonora for her initiative in discussing it with us, and for helping to sort out that the Jewish Medical Association hears more about the incidents, about the responses to it. We're going to have presentations from the panelists, and these are going to be followed by a panel discussion. And as customary in these events, we're going to allow you to put forward your questions and also to participate in the chat. And I will monitor them and present them to the panelists at the end of their presentations. I hope everybody is fully familiar with the very distinguished panel that we have with us tonight. And without further ado, I'm going to introduce Dr. Jonathan Cohen, who is a pediatric infectious disease specialist, to set the background for the polio and for polio in general, and for the various aspects of that polio which he encounters with it, or has encountered within the context of his work. Jonathan.
Thanks very much. Let me just share the screen. Can you all see that okay?
Yeah.
Yep, fantastic. So perhaps I should just preface this by saying I've not seen a case of polio. And I think that's probably true for the vast majority of doctors nowadays in the UK, I would guess, even those who specialise in infectious diseases, unless they perhaps happen to have come across one of the very, very few cases that we saw in the UK perhaps several years ago, or in countries where there are still some cases. And so what I'm drawing on in what I'm going to say today is theoretical knowledge, not my own personal knowledge, but I think an important, hopefully helpful sort of summary. And a lot of this stuff is stuff I think that's familiar to everyone, perhaps a little bit closer to the forefront or the back of their mind, depending on when they last sort of came across some of this stuff. So I'm a pediatrician. I specialize in pediatric infectious diseases at the Evelina Children's Hospital, which is at St Thomas's, part of Guy's and St Thomas's in London. And in fact, so polio has a slightly sort of, through my family, a slightly personal connection, because a family relative made Aliyah in the early 1950s. I went to live in Haifa, and sadly, shortly after that, contracted polio and died. And that, I think, is a sadly familiar story that many people know from family members or relatives from the 1950s. The images we see in the bottom right corner here, this is from the United States, where many children are on iron lungs due to paralytic polio affecting their respiratory muscles. And it's the sort of anxiety and fear of that sort of epidemic is beautifully described in the book Nemesis by Philip Roth. If you've ever come across that, I would recommend it. It's a very good read. Really describes the sort of fear that people have in using swimming pools, mixing with other children, something we've obviously seen more recently with the COVID pandemic, but in the very specific context of polio. So polio is a type of enterovirus. There's 3 different serotypes of polio. It generally causes a higher risk of severe disease to young children and adolescents, and about 1 in 200 who contract it will develop irreversible paralysis. And especially if this affects respiratory muscles or bulbar muscles, it can lead to death in about 10% of those who become paralyzed. And as I'm sure you all know, there is no cure for this, but what we can do is prevent it through immunization. So I'm very briefly going to rehearse some very elementary sort of pathogenesis of polio that's relevant really for the progression of clinical features and relevant for understanding vaccination. And I think what everyone else is going to be talking about this evening, really. So as you know, it's spread through the fecal-oral route, and the virus is able to infect the mucosa of the intestines. From there, it's able to spread lymphatically, hematogenously, and then has a propensity to infect muscle cells, allowing retrograde spread to the spinal cord, or more direct infection through the bloodstream of spinal cord, brainstem, and brain more generally. It's got certain propensity to certain areas, and it has this ability to kill off the anterior horn cells, hence giving rise to the sort of areflexic, hyperreflexic paralysis that we're all familiar as sort of, if you like, the the characteristic feature of polio infection, but one which is only seen in perhaps 1 in 200 cases. And this forms the basis for the general approaches to vaccination. Others are going to talk more about vaccination, but obviously the oral polio vaccine is able to block intestinal infection by giving good gut immunity. The inactivated injected polio vaccine, as used currently in the UK, blocks systemic infection through antibody production, and that will also prevent, specifically in this context, nervous system infection. So both of them are able to prevent polio. The oral polio vaccine is also able to prevent or reduce gastrointestinal infection and spread. And it's been massively successful, polio vaccination. If we look back to just 1988, there were about 350,000 cases globally. And since then, wild type 2 was eradicated, last case in 1999, last case of type 3 in 2012. By 2017, there were only 22 cases of wild type polio virus infection globally. So that's a 99% reduction, with just some cases persisting in Afghanistan and Pakistan at the moment. But the fear we've got in London at the moment, and a lot of polio that's, and worries about polio globally, are not about the wild type virus itself. So when we give the oral polio vaccine, which since 2000, about 10 billion doses have been given to 3 billion children globally, and that's thought to have prevented 13 million cases of polio, it is massively, massively effective. And obviously, the risk benefit is in general is very much in favor of the use of this vaccine. However, it does have a very significant side effect, very, very rarely, that in the primary recipient of that oral vaccine, they can develop paralytic polio themselves. That's known as vaccine-associated paralytic polio. And in the vast majority of cases where that doesn't happen, the oral polio virus, it's a live attenuated enterovirus, and like any other enterovirus that goes into the gut, it will be excreted from the gut, usually over a period of a few weeks, longer in those who are immunocompromised. It is able to spread if sort of fecal-oral hygiene isn't perfect, which it never is in any community, though it certainly is better in some areas than others. And during that time when it's spreading, it can undergo genetic changes, some of which can lead to reversion to virulence. This usually takes months of circulation, particularly in a relatively low immunized community or population, for this to happen. And when this does, and this circulates, this revertant type, this is known as a circulating vaccine-derived poliovirus. On the right-hand side there, you can see some data from a few years back. This is from shown, it's in the Green Book from the what was then Health Protection Agency. And you can see how in the 80s and 90s, most of the cases of polio in the UK were actually in those who'd received the vaccine. So most of that was vaccine-associated paralytic polio. And that was one of the main reasons for switching over to an injected regime that wouldn't have those risks in the primary recipients. Because cases of imported polio, wild-type polio, were so low, the risk-benefits of the vaccine were in favour of stopping oral and going on to the injected, which is what's been used routinely now in the UK since about 2004. So this circulating vaccine-derived poliovirus causes polio. It's clinically indistinguishable from the wild-type disease, and it's estimated perhaps about 1 case in every 3 million vaccine doses. There have been globally about 24, 25 of outbreaks, spread of this within a community. And it's estimated in total there have been less than 1,000 cases of vaccine-derived poliovirus disease globally. And these have been contained successfully by high-quality immunization campaigns on a global scale, usually using several doses of oral polio vaccine. So I mentioned the switch to IPV in the UK that's mentioned at the bottom there. It's clearly a very good vaccine in preventing paralytic polio. It has absolutely no risks at all of vaccine-associated paralytic polio because it's inactivated, but it doesn't give gut immunity to prevent the spread of enteroviruses, including polioviruses, from one individual to another in a very effective way at all. So very finally, to finish, I'm just going to say a few words about clinical recognition of this syndrome. I mean, statistically, it's very unlikely any of us will see this, but I think it is important that we're aware of it and we know what we're looking out for. So the clinical syndrome that would be concerning would be acute flaccid paralysis or acute flaccid myelitis. It sort of has that term with a slash in the middle. You don't know it's myelitis until perhaps you've got imaging or further evidence. The clinical syndrome is sort of indistinguishable between them, though there may be other causes of acute flaccid paralysis on occasion. Often, but not always, there's an identified viral prodrome with upper respiratory symptoms, gastrointestinal symptoms, or systemic symptoms such as fever. There may be a short interval of a few days without symptoms. And then the key characteristic here is the development of a hyporeflexic or areflexid flaccid paralysis. It may often be asymmetrical, sometimes a bit patchy, can affect the head, neck, and trunk as well as the limbs. Sometimes there are sensory symptoms in the early stages, and bowel and bladder dysfunction are not uncommon. Some people don't get this at all and can develop a meningoencephalitis. Some individuals will get some headache, stiffness, and then go on to develop the paralysis. So it's that viral syndrome followed by paralytic features that are the key worrying features that this could be a case of polio, or rarely again, perhaps another enterovirus that is able to cause acute flaccid paralysis as well. So that's a scenario in which we're suspecting it. Be important to test proximal axial muscle and axial weakness, checking cranial nerves, thinking about early referral to neurology and infectious diseases, and early referral to ITU where relevant for respiratory and autonomic support. In terms of diagnosis, so imaging is very helpful in identifying some characteristic features. So grey matter, T2 sequence hyperintensity, evidence of disease in the nerve bodies in the grey matter, often with spinal cord edema, long extensive lesions, longitudinal lesions, but they're not usually enhancing. Neurophysiology will be supportive of this type of pathology as well. And on lumbar puncture, you'd expect to see raised white cells, a sort of lymphocytic predominance, and it gives you a sample for viral PCR and typing. So what should be sent to virology in any case of acute flaccid paralysis is 2 stool samples, ideally a couple of days apart, throat swab or MPA, and if available, a CSF sample. There's very good guidance from the UK Health Security Agency on this that came out late last year. Clinical management of acute flaccid paralysis or acute flaccid myelitis, and that sets that out. And really it's liaison with your local virology team who should be able to send all the relevant samples off to make the diagnosis. As I say, care of this is supportive, so I have absolutely no slides on any specific treatments because sadly we don't have any, and the importance and why we're all here this evening is about prevention. So I'm going to stop there and hand over to the next speaker. Thank you.
Thank you. Thank you. Thank you. And the very useful introduction and setting a background that we're going to be followed up in various ways by other speakers. Now, we're very pleased to welcome Dr. Mary Ramsey, who I've known of her and of her work for many years. And I'm ashamed to say it's the first time we've actually had her come along to the Jewish Medical Association. It should have happened a long time ago because I've worked with her on several interfaith issues in the past. Mary, welcome, and I'll do my best to share the screen.
Okay, great.
Let me.
If you don't, I'll have a go.
You connected? Have you connected?
I don't know. I think it might work, but I don't want to risk it because it might cut me off. But if you go first, if it doesn't work, I'll have a go.
Okay. Right.
In fact, the first few slides actually repeat a bit of what Jonathan's just said, so we can go through those quite quickly if necessary.
Okay.
Not seeing anything yet, David.
Share screen and. There we are.
Not seeing anything yet, David. Shall I?
1 second. Okay.
That's it. Yeah.
Okay.
Yeah. Right. If you can you go back to the first slide and slideshow? Yeah. Yep. Perfect. Yes. Okay. So next slide, please. Yeah, I think there'll be a bit of repetition, so I'll just go through the first few very quickly. As Jonathan has said, paralytic polio used to be a common endemic infection worldwide. 3 types of virus cause the infection. Most infections don't lead to paralysis, less than 1%. And paralysis of limbs and respiratory muscles can occur. And this residual, obviously the main The main complication, other than death, which can occur, is this residual paralysis. Next slide, please. This just summarizes the epidemiology in the UK. So you can see that prior to the 1950s, we had around about 1,000 cases each year. And then there were these increases in the 40s, late 40s and 50s. If you advance, you'll get a bit of text there. This was felt to be due to a change in the epidemiology rather than there were no interventions at this time. And what it was felt to be was that prior to the 40s, people were getting polio as children. When you get it as a younger child, the chance of being paralyzed by it was low. But after the 40s and 50s, because of improved hygiene, paradoxically, people were getting infected at an older age, and therefore the risk of paralysis was low. So although the number of infections probably declined because of improved hygiene, the number of cases of paralysis increased. And this happened in almost every developed country and led to the development and rapid introduction of vaccination. Next slide, please. So as Jonathan said, 2 vaccines. The first one was initially the injectable inactivated vaccine, which is 3 wild viruses that were inactivated in the same way as we do with other old-fashioned vaccines. But they were very quickly replaced by the live oral vaccine in 1961, which contains 3 living viruses that have been attenuated so they won't cause disease. And this vaccine is given orally, and many of us older people will remember having had that either on apocryphally on a sugar lump at school or whatever. And this led to excellent control of polio in the UK. Next slide. Now, the differences between the vaccines, again, going over what Jonathan said, the oral vaccine viruses actually grow effectively in the human gut and lead to a very high level of gut immunity. What that means, though, is that individuals who've been vaccinated will shed the vaccine virus for a few weeks, and this vaccine virus will actually spread to their close contacts and can actually inadvertently immunize them. So that's a good side effect. And so it actually improves the vaccine coverage. You vaccinate, 80% of people, and then 5% extra will get exposed through this spread. So it's very good at giving you protection across the whole population. However, as Jonathan said, very rarely this can actually cause vaccine-associated paralytic polio itself. In contrast to that, IPV gives really good protection against paralysis. It cannot cause paralysis itself, but it gives quite poor gut protection. So in theory, a population that's been vaccinated with IPV can still allow circulation of the virus through having asymptomatic gut infections, but without having any paralytic symptoms. So up until the risk of importation of the virus was so low, we continued to use OPV in this country because we knew that the risk of vaccine of the wild virus coming into the country was high enough, and we wanted to reduce the circulation if that was to occur. So if you advance the next slide, next thing. So in 2000, sorry, back again. Sorry, in 2004, when the global situation had improved and we'd had no polio in the UK for many years, we switched to using an IPV schedule. And we currently vaccinate babies at 8, 12 and 16 weeks as part of the 6-in-1 vaccine. You have another dose at 3 years and 4 months just prior to preschool, and another dose in year 9 when you're leaving school. Next slide, please. So again, a bit of repetition again, but as Jonathan said, poliovirus type 2 was actually eradicated in 2015, the last case being back in 1999. Type 3 was eradicated in 2019, with the last case having been in 2012. So the only remaining wild virus is the polio type 1. And as Jonathan said, that's now very rare. So because of this, since 2016, the WHO has recommended that a trivalent oral vaccine should not really be used. And actually, we should be using either the bivalent with types 1 and 3, or preferentially, if you haven't got type 3, the type 1 vaccine. However, due to supply issues, several countries worldwide have continued to use OPV up until at least last year. And in particular, it was used in both Afghanistan and Pakistan to control outbreaks of type 1 in those countries last year. Next slide, please. Now, as David said, when you get to the point where you're near eradication, if immunization rates are low, one of the concerns about using OPV is that the vaccine viruses can spread during the community, across the community, in the same way as was a good thing before we got rid of wild virus, but it becomes a bad thing now in the situation where we have no or very little wild virus left. Because during the spread in the community, if vaccination rates are low, the vaccine virus will persist in the community, and over a few months, it develops mutations, and those mutations make the vaccine virus more like the wild virus, and it has potential to cause paralysis. And this is called vaccine-derived poliovirus. And when this circulation continues for several months, this is then designated as a circulating vaccine-derived poliovirus. And this obviously increases the risk that anyone who is unvaccinated could be exposed and potentially develop paralysis. And as Jonathan said, CDVPs have now caused relatively small outbreaks of paralytic polio in several countries. Next slide, please. So one of the ways of monitoring this is through sewage surveillance. And this has been recommended by the WHO for some time now, but it's actually technically and logistically quite a difficult thing to do. It depends a bit on what your sewage systems are like in terms of how effective and what the yield of this kind of surveillance is. But it basically acts as an early warning for picking up the virus before you pick up any cases. And so we've been doing sewage surveillance in the UK since 2016. And the concept is that obviously people excrete polio in their stools, it gets into the system, you test in the sewage at a high point where you're getting main drainage from the sewage from potentially thousands or millions of people. And then you can detect the virus using very selective culture media that grow poliovirus, type the virus, and that gives you early warning system. Next slide, please. So since 2016, we have, working with the National Institute of Biological Standards and Control, which is now part of the MHRA, we've been testing raw sewage samples collected from London and Glasgow every fortnight. And the National Institute has the WHO Global Specialized Laboratory, and they're able to both grow the virus and then type it and tell us really what's going on. And on average, we've been picking up polio in the sewage, mainly in London, about between 1 and 3 poliovirus have been picked up every year through that sewage sampling. And these have tended to be a single detection, which is then the next sample has been negative. And when we've typed the virus, we've shown that actually the virus is pretty much identical to the vaccines that are used. And so the concept, we think, or the hypothesis is that an individual who gets vaccinated overseas, excretes the virus, comes to the UK, maybe on a short-term trip, or maybe comes back to the UK from having been away, and stays here and excretes the virus into the sewage. But after a few weeks, they clear it, and then the sample becomes negative. Next slide. However, this year, we detected a vaccine-like poliovirus way back in February from the London Beckton Sewage Treatment Works. So this actually is our London sampling site, and it drains from around 4 million people in North London. The difference this time was that the same virus was picked up again in April and has been picked up persistently ever since. Like the other situations, hypothesis is that we had someone who'd been vaccinated abroad and entered the UK in early 2022, and that individual was excreting virus, having been recently vaccinated. But now that virus had started to spread in the North and East Central London areas, presumably due to the fact that they have suboptimal vaccine coverage. So it's an area of the country where coverage has always been lower, And during the COVID pandemic, unfortunately, coverage has slipped again a little bit. And I think Leonora will show you some data later. The problem with this continued excretion is that the virus has continued to evolve, and since June has had sufficient mutations to be defined now as vaccine-derived poliovirus, which means it has potential to cause paralysis. So by August, we'd actually had that going on for 2 months, which means we now have officially circulating poliovirus. Now, the UK, we've only detected it in sewage samples. We don't know which population it's circulating in, and we've had no associated cases of paralysis. So that's the good news. The bad news, and I guess why your community may be particularly interested in this, is that a similar situation has now been found in the New York State in the USA, where they picked up actually a case of paralytic polio. And this was in an unvaccinated adult who was a member of the strictly Orthodox Haredi population. And they then went back and tested sewage samples, and sewage samples in that area tested positively. Similarly, in Israel, a vaccine-derived virus has also been detected in sewage there. The Israelis have been running sewage surveillance as well for some time. And what we've now shown is that the viral typing confirms that the viruses we're seeing in London, in New York State, and in Israel are the same, or are sort of genetically linked, I should say. They're not identical, but they probably come from the same source. So this is this sort of gives us a little bit of a hint that this may indicate that the circulation we're seeing may be being particularly circulating in the Orthodox Jewish population that we know lives in that part of central and northeast London. So I think that's all I was going to say, and then maybe Leonora will tell us a bit about what we've been doing to respond to it, and I can fill in any answers to subsequent questions later.
Thank you very much, Mary, and we now turn to we've had the background, and we've had the background about the clinical condition and about the virus and about how it's detected. Now we're going to turn to Leonora to explain how one responds to this. And I will just again set up the screen share, and hopefully manage to
Thanks so much, David. I've just introduced myself for those who don't know me. So I'm Leonora Weil. I'm a public health consultant at the UK Health Security Agency in London. And I'm also co-director of the COVID Legacy and Equity Partnership. So learning from COVID to reduce inequalities in screening, vaccines and access to healthcare. So really, I'm going to cover today, and my slides will highlight some of that, but we'll have a look at some of the data. We'll think a little bit about why we're looking at this now. And then in particular to think about what we're doing to work with the Jewish community, specifically in London, and then really where next. And I know this is a panel discussion and there will be questions for us, but it's also, we're in an opportunity to have the Jewish Medical Association together, so to pose questions back to the audience, to ask you where you think we can make most effect and support the community in the best way possible. So really, why are we, and again, while we're waiting for the slides, why are we thinking about this now? And Dr. Mary Ramsey and Johnny highlighted the findings in the sewage, and we know anyway that vaccine uptake in London is low, and we're on a background of that, thinking about how the spread can impact the Jewish community. But I think it's also important to think about the context of where we are now, in the context of coming out of the COVID-19 pandemic and one of the biggest vaccination drive in NHS history. And there was a lot of learning from that we can take in terms of engaging with communities, tackling conversations around vaccine hesitancy and what that looks like. And also thinking about new ways that we can work with vaccines in new spaces, new partnerships, and new initiatives across our health systems in supporting vaccine uptake. So I don't know, David, are you happy with the slides or?
Your slides, you're not seeing the slides?
Nope.
Sorry. I thought I've got them showing here, so I assumed you were seeing them. I assume you're seeing them. Go back to shares. Take. Can you see that now?
No. Do you want me to try and share?
Have you got that?
Yes, that's great. Thanks, David.
Yep, there.
Great, thanks. So yes, as I outlined, we'll look at some of the data, the system response, we'll look at the Jewish community and think, what next? So if we just skip to the next slide.
Should be on. Why are we talking about this now?
Yes, but we can skip to the next one. That's great, thanks. So just looking at some of the data now, and I'm just going to highlight some of the uptake for the 5 and 1 for the London region, and this is looking at cover data at age 2. And we can see for England and in London, we're below the WHO target of 95%. London uptake is been for some time lower than England, than across England compared to other regions. So we're not in new territory here. We have seen this before. And much of this has been exacerbated by the disruption to services caused by the COVID-19 pandemic. Recovery for some of the childhood immunisations has started to recover and pick up in the last quarter of 2021, 2022, but not the 5 and 1 at 24 months. And we do await the latest publication of the 2022-23 quarter 1 cover data, but that really highlights what we see across London with uptake being lower. And what more we can see within London, that there is variation across the different boroughs that we have within the capital. So on the next slide, this is just looking at population coverage at age 5. And that's for the 5 and 1 by borough. So you can see some of that variation, and I've just highlighted there uptake from Barnet, Haringey and Hackney. And if we move to the next slide, again, you can see some of that as a visual representation of that primary vaccination course, the range within London from 93.4%, but as low as 61% in some of the boroughs. And again, looking at that north central area within London, specifically Hackney there. And on the next slide, this is the preschool booster. Again, looking at that range, 84.7%, but going as low as 54.2% in some regions. And I think what's interesting about these are very visual representations. If we go to the next slide, this shows and highlights some of that sewage sampling that Mary had highlighted across London. So looking again at that northeast, north central area, where some of those samples have been found in the sewage treatment centres. And again, that really superimposes on some of the low vaccination coverage, and therefore that significant overlap between the local authorities with the lowest vaccine coverage and where that vaccine-derived polio has been detected. So on the next slide, what are we as a London system response, what have we done and what can we do about it? So there's very much been a partnership approach, and that's been working across health organisations and wider partners to join up those responsibilities and to deliver the response at pace. There's been that situation investigation, so continuing to look at sewage sampling, and that's been expanded nationally to look at areas which are at the highest risk of new poliovirus importations, and again, looking at in the likelihood of low vaccine uptake in specific areas as well. And importantly, and this is you'll be familiar with, the Joint Committee for Vaccinations and Immunisation Advice, advising the NHS to urgently launch this polio booster campaign for children aged 1 to 9 within London. For some, this is an extra dose of vaccine, and for others, this is bringing them up to date. And the aims of that campaign are really twofold. So providing and strengthening that campaign against paralysis, but also with the aim of interrupting that transmission that we've seen highlighted through the earlier presentations. And again, looking at all of that against the background of a high density population in the areas affected and the under vaccination in those areas. So in terms of delivery, parents have been urged to check their red books to look at their vaccine uptake, and there is a call that has gone out for the 1 to 9-year-olds across London, invited by 26th of September is the goal, and the aim is for around 1 million children to be vaccinated as soon as possible. I've just picked out here some of the, if we go back a slide, some of the outbreak material that has been in the Jewish press, so both coverage in the Jewish Tribune, for example, and the JC, highlighting some of that call for vaccination, but also less positive press around that rare risk of the oral vaccine. And some of you will have seen a Daily Mail report that was in the newspapers over the weekend as well. So if we move to the next slide, key to the campaign as well is as Johnny highlighted, the healthcare professionals being alerted to the programme, but also working to support communities that might be particularly vulnerable. And there's been specific focus work to support uptake in the Jewish community. And this is on the background of the Chagim coming up, and how we best respond. So really the approach has been a 3 phases approach. So phase 1 was very much an immediate response. So over August, working across organisations within the community with communications leads at both NHS and the UK Health Security Agency, lessons as Ben will highlight from New York and some of their campaigns, but really to get a response out there really quickly with some of those key messages, and that's gone out. Phase 2 has been more of a discovery phase, and I say that, I know partners on this call and partners working in the vaccine space have worked with the Jewish community for many, many years on working on vaccine hesitancy and supporting vaccine uptake. But specific work that has been done is first of all working with the London Jewish Health Partnership. And the London Jewish Health Partnership came out of the COVID-19 vaccination, working to bring health professionals together directly with the Jewish community. It includes representation from the Jewish community, London Jewish Forum being the anchor organisation, and key contacts within the Haredi community as well, but really working with local public health teams, NHS, GLA, UK Health Security Agency, and being able to have those discussions and bring partners together very quickly in response, and therefore has been really useful in this instant in being able to bring together both the ideas but also the delivery. And coming from that was a deep dive workshop with the community and with health professionals last Thursday. Some of you, I think, were on that call. We had over 100 representatives, again, from across the whole Jewish community. We had New York there, we had Salford, we had various different organizations, and again, opportunities to engage with and think about the next steps in this space. We've got the panel discussion tonight, and really engaging and working with health partners on the next steps. And that really is phase 3. So some of it will be working very quickly, but also waiting for an action-based delivery in response to some of that discovery. And that will all be pulled through an evaluation led by LSHTM and the UK Health Security Agency. So again, I think in that, some of those conversations and some of those discussions with the Jewish community have really come up with some building on ways that we can work. So it was an opportunity to bring together health and NHS communications leads with the community and produce very bespoke and co-designed material, but also new ways of thinking. And again, and that's why I mentioned the COVID ways of working. Can we bring in vaccines in new spaces? Can we think differently about the delivery? So vaccinations in schools, vaccinations in different health settings. And we've already had, based on that workshop on the 15th, great ideas of how we can roll and think about that moving forward. And that's where we'll come to you for your thoughts and ideas on some of those ways of working, and what you think in your capacity and in the ways that you've been working will be best to take this forward. And there is a huge appetite and partnership within health organisations to take these ideas forward. And then just on the final slide, I just want to leave a bit of a reminder to all partners about other vaccine preventable diseases. And I know that we are talking about polio this evening, and polio is the immediate threat that we are talking about based on the findings. However, we know that vaccine rates are low across London, but also within both the Orthodox, but also general Jewish community, both in London and more generally. MMR rates are low. Measles is a focus of UK Health Security Agency around the corner. And we know as well from conversations with communities, we work in silos in our health organisations, but they don't. And much of the discussions they want to have are much more rounded, both around vaccines more generally or around those health. So I think it's important when we have those conversations and we have these conversations that we're not just thinking about polio, but we are thinking of the broader vaccines that are in space. And I will hand over to further speakers on this issue.
Right, thank you. We'll just close that. Thank you very much. We now turn to one of the local practitioners, well known to the association and also to the population of the Hackney area of London in particular, Dr. Joseph Spitzer.
Good evening. Just a second. Right, you can hear me.
I can hear you.
Good. So I've been a GP in Stamford Hill, which is in North Hackney, for 37 years. Approximately 85% of our patients are drawn from the local Haredi community. And over a third of our patients are children under the age of 10. So immunization is extremely relevant to this population and to our work. As you've heard, the uptake of immunizations in the Haredi community is far from ideal, with less than 25% being fully immunized at the right time. Now, this is nothing new. It's been the case for decades. The topic tonight is polio vaccine, but I believe that this is no different from any other immunizations offered to Haredi patients, and its relatively poor uptake by them. Having worked with the Haredi community for so long, I'm familiar with all the arguments used for not immunizing. At this stage, it's important for me to make it very clear that I am obviously fully 100% in favor of vaccinations. My patients know it, which sometimes leads to interesting discussions, if that's the right word, with my vaccine hesitators or refusers. I often ask them why their child isn't immunized, and I've heard all the possible answers or excuses. I can list them, it's a long list. I'll list just a few of them. He or she is too young for his immune system to cope. Let him get stronger first. Or fear of the side effects. My such and such relative had it, or their child had it, and they developed goodness knows what disease from it. It causes autism. Our family don't believe in it. Or there are too many things in the vaccines. We want to give them separately. Or our rabbi says not to do it. But in truth, I've yet to meet a rabbi who has said that. But the next excuse is the worst of the lot, and gets me angry every time I hear it. If everyone else does it, then we don't need to. These are just some of the excuses I hear. I'm known for my strong pro-immunization views, and I don't mince my words when, say in response to, but he's too young and his immune system needs to develop, or such similar nonsense. I'll say, well, you'd better immunize him before it's too late. What do you mean by that, says the parent. Well, I say, you can't immunize a child who has died from measles and encephalitis. Strong words, I know, but sometimes we need them. Parents who use the herd immunity excuse from me anyway, parents who don't immunize their children are irresponsible, not just to their own children, but to other children, people's children as well. I believe that the urban myths, the misinformation and parental views, which in the Haredi community often means the grandmother's views, and peer ignorance are all believed much more strongly than medical truths, facts, and information. Of course, ignorance is best dispelled by education and the provision of accurate information. The local Haredi press has published some good informative articles on immunization, but this has been balanced, if that's the right word, by articles giving the anti-vax view, often with spurious pseudo-scientific arguments. Hackney has produced some good Yiddish language information leaflets on immunization. However, there's definitely a strong sense of mistrust of the authorities and the medical profession when it comes to immunizations. One of the rebuffs that I get when discussing immunizations is, well, you would say that you get paid by the government to promote immunizations. This applies to all immunizations, being it the regular child immunizations, the annual flu vaccine, COVID vaccines, and of course, the polio booster vaccine under discussion tonight. Some 25 years ago, we had a major outbreak of hepatitis A, and we undertook an intensive immunoglobulin injection program. Here, numbers were boosted by school exclusion policies made by some of the local Haredi schools. There have been many, many initiatives over the last 35 years which I've been in practice in Hackney. So many that I've lost count of the meetings I've attended to try to improve vaccine uptake in the Haredi community. Money has been lavished on trying to improve uptake rates, but none with any sustained improvement in uptake. One thing I'm certain of low uptake rates are not due to poor access to services. Access is generally good. When more points of access are provided, it makes it easier for those parents who do want to immunize to do so. It does not seem to increase overall access over time. I believe that in this particular population, the only way to achieve high uptake rates would be some form of coercion, such as school exclusion. A pediatrician friend of mine working in New Jersey in the United States with a similar population told me that he will not take on any families who don't or have not immunized their children. We here in the UK are unable to do so. It would be regarded as discriminatory and a breach of our NHS contract. Similarly, schools may not exclude children who are not immunized in many parts. In many parts of the USA, they can. I often get asked, why don't the rabbis say anything? And sometimes the rabbis do encourage immunization, but are ignored by many. In addition, I've heard more than one rabbi say, this is a medical issue, not a religious one, and therefore ask a doctor, not me. There's much complacency due to vaccines having been a victim of their own success. Most of our patients have never seen a case of paralytic poliomyelitis. I have. The last major outbreak of polio was in the 1950s. I recall patients walking with crutches and calipers, but my younger patient group don't. I really hesitate to say it, but I really don't think uptake of the polio booster or indeed primary vaccination will increase unless there are actual cases of paralytic polio in the Haredi community. Then the rates might improve. I say might. I hope we don't have to see if it will. I'm sorry to be somewhat negative, but based on my long experience, the uptake of the polio booster vaccine will not be as high as we would like, but that doesn't mean we shouldn't try. Thank you. Thank you. David, you're muted.
Many issues that I'm sure we'll be discussing further. And finally, I'm going to introduce Dr. Ben Caston, who is the relative newcomer, if you like, to the London field. He isn't quite as much a newcomer as he may appear to be, because he has been interested in this subject and the of immunization right from the beginning of his career. And he's also done extensive recent studies during the COVID-19 pandemic. So Ben.
David, thank you. I'll just share a screen. Perfect. So I hope that you can all see that. Great. Okay, Dr. Spitzer's nodding. So thanks again, David, for the invitation to join the panel. And I guess my contribution to the question of what are the priorities in the polio incident response is from the perspective of inequalities in coverage and vaccine engagement. And really by vaccine engagement, I just mean this crucial relationship between public health and primary care and parents and populations. So obviously, the short-term priority is to deliver the IPV booster program to children aged 1 to 9 in London, as Leonora and Mary outlined. But the question is really how, and how do we do that with known issues around access, which Dr. Spitzer challenged, and also issues in engagement. And in this presentation, I'll really focus on Hackney as a case study, but it does raise broader implications for London and for the rest of the UK, depending obviously on how the incident evolves. So just in terms of background demographics and context, the most kind of publicly available and recent data that we have is from the 2011 census, when the UK Jewish population was measured to be approximately 271,000, and Haredim were about 12 to 16% of that figure. And that figure is rising because of higher total fertility rates in this community, which are about 3 times that of the national average. And then if we just hone into Hackney for a second, it has the largest Haredi neighborhood in the UK. And whilst, again, this is going back to the 2011 data, so things may have changed, that approximately 7% of the population are Haredi, but the child one in 4 of the population, of the child population are Haredi, so about 22%. And that brings challenges and considerations for vaccination and primary care services. So I know that we've had a little bit of a look at the data, so forgive me for repeating it, but the national coverage in the year 2020 to 21 for IPV at 1 year was 92% in England, and Hackney falling considerably shorter than that. And then if we look at other areas in England with sizable Jewish communities, we see variation in the coverage. Now, obviously, as Mary said, we don't know which populations poliovirus is circulating in, but we can get a sense of who might be vulnerable to circulation because of lower level coverage. And then at 2 years, we can see that the coverage levels in Hackney pick up by about 10%, which might give us cause for optimism that there are issues of delayed uptake rather than kind of refusal that's unchangeable. And again, in terms of that vulnerability, if we just look back at the last 10 years, there've been a pattern of vaccine preventable disease outbreaks in Hackney. measles outbreaks in 2012 to 2013, pertussis, the measles outbreaks in 2018 to 19, and again, this lower level vaccination coverage clearly signaling a vulnerability for the Haredi community with ongoing circulation. So just in terms of the background of some of the kind of health responses, the World Health Organization's Regional Office for Europe developed a methodology called tailoring immunization programs, which is really premised on integrating research into vaccine delivery. One of the first and pilot studies of the TIP was conducted in North London with the Haredi community in 2014 to 16. And that identified a few issues such as unmet information needs and, for example, less digital access and a need for more printed information. We've got evidence to suggest that maybe things have changed with COVID-19, with communications circulated around social media. So perhaps in the last 6 years, there have been some developments there. And barriers such as inaccessible and inflexible services, which again, we'd heard from Dr. Spitzer that perhaps those aren't so much of a case today. And some of those recommendations that had come out were Sunday clinics or more local points of delivery. We know that there's been limited translation of those recommendations into action, and that's often because of commissioning and funding constraints. And I think that there was a question actually in the Q&A about this, of the limitations on offering vaccinations in alternative sites. And there's also less vaccine delivery via the Haredi school system. And one of the most recent developments in the COVID-19 pandemic was a more localized and co-delivery approach that we'd seen with a select number of vaccine clinics offered by Hatzolah and GPs, which really generated an opportunity for local level delivery, but also a kind of shared ownership of the program. And this offers some opportunity for exploring the sustainability of these local delivery methods to benefit routine childhood vaccinations. And that's just an image with some of the kind of celebration around that. But at the London School, we'd conducted a study to really understand how did this look in practice and the kind of divisions of roles and responsibilities in this co-delivery model. And some of the kind of three key points that emerged for us was the need for sustained financial investments, because these kinds of partnerships can be quite expensive. The need for a commitment to engagement, for example, initiating collaborations if they're not in place or upscaling them if they already are. And again, a clear approach to coordination and understanding different roles and responsibilities and who would do what in these vaccination programs. So they require quite a lot of thought and planning, which are sometimes not ideal for a short-term response. So we've heard a little bit about the polio incidents and responses in terms of the IPV delivery. And again, Leonora, please feel free to jump in if you want to contribute or add to this. So the current plan, I understand, is to offer children aged 1 to 4 IPV boosters via primary care services, and to offer children aged 5 to 9 or 6 to 9 in some places, IPV boosters in designated vaccination sites or concentrated delivery points in target areas. So for example, community pharmacies and vaccine centers. The good thing about designated vaccination sites is that they're great at serving numbers, but sometimes less equipped to address inequalities in tailored ways. And we know again from the COVID-19 pandemic that designated vaccination sites, or mass vaccination sites as they were called, were viewed as being less convenient by local level public health professionals, who instead regarded that the localized services were considered to increase convenience and confidence, and hence uptake among the higher risk groups in Hackney. And then this raises a question that we can possibly discuss today, is are the designated vaccination sites the most effective way to approach polio vaccine engagement in the underserved minorities that are most vulnerable to circulation, or as Leonora has suggested, looking at new or alternative sites, or the question in the Q&A. And here we need to, again, learn from past learning and apply that into the ongoing incident management. And bear in mind that localized delivery is never going to be cost neutral, but really to think of it as an investment against the backdrop of vaccine preventable diseases that we've seen. And in terms of looking at vaccine engagement, this is a production from Manchester, going back to 2015 and the measles outbreaks. And it was developed or produced by Interlink with some statutory funding, which really situated these issues around vaccination in a broader conversation of maternity care and family health. Unfortunately, these were discontinued. And in that space, looking and following the High Mission circulars that get delivered to every single home, we see these messages against vaccination, quite clearly implying that they're toxic. So to give emergency essence, whatever that is, to stop allergic reactions and to clear out toxins after routine vaccinations. And it raises again a question of what information is counterbalancing these harmful messages, and how can we have a sustainability or continuity in the resources that are delivered to parents. And then we know that there is also targeted misinformation, and that issue is more acute in Israel and the US. The pictures that you can see on the left and the right were from an event held in Jerusalem that I went to just before the 2019, just after the 2018 to 19 measles outbreaks and before the pandemic. And the picture in the middle, who might be known to some of you as Del Bigtree, who is an activist against vaccination in the US and was brought over to Jerusalem to speak to Haredi communities in Jerusalem. And really inspiring distrust and religious objections against vaccination, arguments that we might see more in the US, but also bringing them to Israel. The thing to bear in mind is that the reach or the impact is difficult to measure, and again to ask, is this the primary issue? And those GPs will have a clearer idea of that and be interesting to talk to them about it. Or is delayed uptake and timeliness a more strategic priority to focus on in the medium to long term? As Leonora mentioned, we'll be doing a service evaluation together to look at the delivery of the IPV booster campaign, particularly in Hackney and Haringey, to evaluate the vaccine delivery models and whether and how they increase uptake, and whether the IPV booster campaign has been informed by past learning in outbreak responses, and how might any lessons from the booster campaign be integrated into a longer term strategy for vaccine engagement. And just to now look at the kind of longer term priorities in vaccine engagement, addressing persistent vaccine inequalities through localized approaches might be one way to do this. It goes without saying that routine services must be accessible to facilitate uptake, and that's the overarching goal of delivery, because the ultimate aim of vaccination services is really to serve child health and population health. But we also really need to appraise what funding and provisions are required to offer those tailored services in a sustainable way for underserved populations and to ensure sustainability. And some of these conversations might be relevant to the Haredi community and others like them. So in terms of what we've known from Hackney, that there are requirements around clinics and space and flexibility, that there are issues of targeted activism against vaccination. Again, that reach is difficult to measure. And focusing only on this as if it's the only issue can influence interventions in unhelpful or unproductive ways. We know that women tend to be the key decision makers around vaccination in the Haredi community, and often there is an issue of delayed uptake, but again, that's a timeliness issue rather than a mass refusal issue, and that can inform our approaches. And parental vaccine engagement can be quite specific. So any kind of questions around MMR safety or the HPV may be different to IPV, and we should be cautious about translating them or imposing them onto the booster campaign. And in our experience, really, rabbis are rarely consulted and are not often cited as key influences on vaccine decisions. Rather, it's female networks tend to be consulted, which really encourage or might encourage us to put women at the heart of the longer term strategy in vaccine engagement. And just as a summary of those short and long-term priorities, it's better understanding the priorities of parents, how they perceive vaccination amidst the polio virus response. Again, those questions of timeliness, and whose opinions they value most. Continuing to produce targeted communications, as we'll be doing over the next couple of months, with urgent but reliable information. And against those concerns that I think Dr. Spitzer mentioned about trust in local authority and government, to really frame vaccination as a way to protect the future of the Haredi community and its growth, because a Talmid Chacham at the end of the day will learn best in yeshiva and not from the sickbed or the hospital. And really to continue thinking about sustainable and complementary delivery pathways, integrating them into the existing service beyond one-off pop-up clinics, which tend to have very specific funding arrangements. And again, in the longer term, to help think about proactive and not reactive healthcare systems, and to really have the mechanisms in place to translate documented knowledge and evidence into action. And I think I'll stop there, and hopefully we should have enough time for conversation and questions.
Right, thank you very much. That was really, we've gone through an enormous amount of ground, and from beginning to end, and looking forward towards the future. And much appreciate the efforts made by all the panelists to do this. Now, I've got a couple of questions listed, and as usual, there are ones coming in now. But can I just start off by asking one about the detection? Mary, we're talking about poliovirus detection. Are there any other viruses that are being detected, and changes in the patterns of other viruses being detected, or is this the only one that's actually having this kind of strange pattern of suddenly detecting large numbers of what is presumably a vaccine strain?
Do you mean specifically in sewage? Is that what
Yes,
you're
in
talking about?
sewage, in
Yeah.
sewage.
So I mean, one of the problems with looking in sewage is you can find lots of things, and
Yeah.
the method that we've been using for polio puts the sewage up on selected media, so they only grow the viruses we're interested in. So essentially, the standard method looks for poliovirus on L20B cells, and then we also do enterovirus, and we very commonly find non-polio enteroviruses, not surprisingly, and they show a seasonal pattern throughout the year. Obviously, during COVID, it was used quite extensively for that, and you can certainly find most other gastroviruses in sewage, hepatitis, and we have considered using it for other diseases. I think the difficulty is how it would help you, because when you can't link it to an individual case, and I think that's what the experience was with COVID, was that you couldn't, for example, looking for variants, you couldn't then go and work out how to control that variant because you didn't know who it was coming from. Yeah,
it might have given you some indication. For example, in the case of Leicester, might have given you some indication which area of Leicester had.
Yeah. I think it's incredibly, it sounds simple, but it's actually incredibly time consuming and expensive, particularly if you want to drill down to geographical area. Yeah. And that's why we went for Beckton initially. Yeah. And that was like, getting 4 million people in one go. And then when we found the positives, we ended up going down to lower levels. But really, if you go down below several 100,000 people, you begin to, it begins to get, you can imagine the amount of sampling. It's very labor intensive. And actually even collecting the samples is quite difficult. We've even, we've had to stop traffic to get people to go down manholes to get sewage samples when you want to get that localized information. So it's clearly possible. It's just you have to have a good reason to do it, I think. And polio is the one example where it's been used really effectively in public health terms.
So it's a long way from my work in a pediatric hospital, first laboratory work looking for amoebiasis and looking through every stool sample that came into the children's hospital in Cape Town to actually see whether any of them had amoebiasis, which it's a lot more scientific these days, I suspect. Also in relation to comparators, Leonora, with the geographic distribution, one is struck by the minority ethnic populations in those boroughs. I mean, the interesting juxtaposition of Hackney and Tower Hamlets, which Tower Hamlets doesn't appear to have virus, whereas Hackney does, and the same pattern, in fact, didn't that occur with COVID? So are these geographic patterns overlapping to other ethnic minorities, and are there differences in the ethnic minority distributions?
I think Mary can probably say more on this as well, but I think, you know, we can't tell from the sewage exactly where it's come
No,
from.
I'm not talking about the sewage. I'm talking about the population incidence of incidence.
Yeah, we can look at patterns, and I think, you know, I'm going to pull this back to what we've seen during COVID, and we did a lot of work with communities during COVID, really engaging, really working with them. And what we had during COVID from the COVID data was we had excellent ethnicity data that we could look at, analyse, and therefore follow within the work that we were doing. I mean, you can't attribute, and this is also talks to Penelope's question in the chat, you can't attribute, because of these big campaigns, specific actions to their results. But we were able to see focused engagement with different communities, how those communities' uprate levels changed. But what we did see, and I think there were key things that Ben has highlighted in his talk that we've seen across communities, common themes between those that we spoke to, big issues around mistrust being a huge issue, and not wanting to only have health professionals talk about the things that they want to talk about, to be able to talk about the issues communities want to talk about, the issues around co-design, being engaged with, not just talk to. So there is a lot of similarities we see with the communities that we're working with more generally, but also a lot of common things that we can see in terms of our learning. And that's why I think as we come into it in this space, again, so Penelope, you've talked about the Somali community. There's lots of initiatives that we were able to do, and we look at the kind of the three Cs that the WHO highlights in terms of increasing vaccine confidence. We can bring those into the conversations and the aspects of work that we're doing, and that's why I think when we come into this, we're working with the Jewish community, we're working with those key partners, but we can bring in new and different ways of working that we've seen elsewhere, and give it a different way of working. And I think that's why we've had another question around outpatients and A&E, opportunistic vaccination. That's something we've done in a different context, but really nice to see how we could perhaps bring it alive for the Jewish community in this way. So I think really in answer to that question, there is hesitancy, there is across different communities across London, but there's certainly lessons that we can work with and learning that we can apply to all those different contexts.
Right, we've got reflected in some of the aging population in the medical association. We're reflecting some questions about matriarchal grandmothers being an important having an important impact on the systems, and also the question of are grandparents actually at risk in a situation like this in any kind of way. I don't know whether Ben would like to tackle the first one, and anybody who tackled the question of adults being affected, infected. Ben, do you want to tackle the first one about grandmothers?
In terms of grandmothers as a source of influence and knowledge, definitely, and I think not limited to grandmothers, also mothers and female kind of relations and relationships, and that's often how those messages of any persuasion might circulate, and increasingly understanding that might also be over social media, and not only word of mouth, as past studies have put it.
You're raising an interesting point, and can I just pursue that one further? What about the role of social media? Has social media, you've had experience in the measles field before. What does social media, has the increase in use of social media had an impact in this instance different from others?
Well, I mean, again, we're talking about a really, really heterogeneous and diverse population. So it will be used in different ways by different people. And in some cases, it won't be used at all. But definitely have seen those messages circulate between, say, New York, Jerusalem, Antwerp, London via social media, WhatsApp messages that can be easily forwarded, for example, ways of, normal routine ways of keeping in touch often being used to circulate vaccine messages. Some of them more problematic than others,
Yeah,
shall we say.
Sorry, and you've raised another question. You've raised the question of Antwerp. Is there a similar problem to this in Antwerp?
I haven't heard of it, but I don't know where they're at in terms of their wastewater surveillance. Perhaps Mary can speak better to that.
Yes, I don't know that either. I do. We have had always when we've had measles outbreak, we've tended to have cases in Antwerp as well. But I'm not aware whether they do sewage surveillance. So I've not heard that. So it's possible they don't do it.
And Johnny, have there no adult cases that we know of arising in recent years of polio?
Mary's probably a better place to answer that.
Yeah, I mean, I think the case in the New York State was an adult Haredi man. My understanding, he was a sort of youngish adult. I don't know precisely how young. I think obviously, if you've lived in a vaccinated population and the states have been using IPV for longer than we have, then you may have some susceptible young adults. Anybody who's not been vaccinated will be susceptible. Older people may well have been exposed to natural virus way back in the 50s, or potentially when oral vaccine was being used, they would have been exposed through the community. So I don't think the very elderly are particularly at risk. It may be that younger adults are at risk in those countries where we've had, established programs for a long time now. But I don't think we've had any. I mean, I can't remember the last. We haven't had a case here for so long. I can't remember what sort of ages they were, but I think they were mainly children and mainly either associated with importation from India and Pakistan, being one of the last few countries to have wild polio, or from vaccine itself. Yeah.
The issue. I'm not sure if I'm interpreting you correctly, but you implied that the UK and Israel were doing sewage sampling, but the United States was not.
They weren't routinely. So after they got the case, what they did was they went back and got the samples that had been collected for COVID surveillance and tested them for polio, and found that the virus had been around. Now, had they been doing the polio beforehand, maybe they'd have had a bit more warning of this case. But my understanding is this individual was avidly anti-vaccine, and even despite having had polio, he still is not having vaccine. So Ben may know more, because I know Ben went on a trip, didn't you, to New York State?
I did, but I think I'm a little bit limited as to what I can say at the minute as this is being recorded. So I think I'll just stop there for now.
Right. Thank you. Right. Okay. That sounds like the American system, in its full-fledged operation. Dr. Spitzer, do you have any comments about the further comments about having heard what Ben has had to say?
Interesting. I think New York, the United States, New York Haredi community, Antwerp, Israel, they're all actually one large community with a tremendous amount of movement between them. The anti-vax literature that was coming out of New York State and New Jersey was extremely well presented and was circulated widely in Stamford Hill, very widely. High quality publication of absolute rubbish and nonsense, but presented really well. And I think I had quite a deleterious effect on the uptake of vaccines for a while. I can't put my finger on what it is. I have got no answers for you. I've been working for so long with this community, and I still can't put my finger on the one answer, because I don't think there is one. And I say it again, only a tragedy would actually boost numbers really significantly. I quoted 25% as a specific. That is the best figure I could find today. Some of our immunization rates are in single figures for timely immunization. Also, it proves somewhat with delay and over time. But it is an appalling situation, and you're right, it's a matriarchal society. The trouble is that the mothers are quite young, and what we need is the great grandparents to be telling about the days when they saw classmates die of various infectious diseases. They're not around, and we've now got a young population of quite strong, influential grandmothers. Difficult situation, difficult community to work with. Yeah.
David, can I just quickly add on what Dr. Spitzer said, because the productions that were coming from the US are well-funded and very well-oiled and well put together. And again, it's about having, these consistent ways of pushing back against that, and having the funding that's sustainable in order to keep producing those, and making sure that they're local, whether that's in London or whether that's in Manchester.
You saw a slide before of the two press releases, the Jewish Tribune on the left and the other one. If you read them, go back some and read them quickly. The Jewish Tribune one was actually quite a negative headline.
I think it was reproduced from the Independent.
Right, it could well have been, but it's not the right. The headline message was actually not the one we would want to circulate. At a quick glance, it was quite a big, bold, negative headline.
The problem about that is the Daily Mail. I mean, what's Leonora doing about the Daily Mail?
So it's a really, really interesting discussion around how we deal with misinformation. And again, this is what we've had throughout COVID and how we respond to it. And we don't always respond head on. Often the advice from our communications colleagues is not to respond directly to it because it can bring attention to it. So it is using those other ways of sharing that information and making sure that those who we're trying to reach have the information and a space to make their own informed decisions based on the correct facts. And I think, again, there's messages in the chat around community champions. You've mentioned the matriarchs and their role, providing Q&A spaces for people. We had a really nice event that we ran in partnership with the London Jewish Health Partnership back in March, which was a live event for over 100 Haredi women, not just about vaccines, but broader health discussions, which really allowed them to engage with GPs and dental leads and key women in their community, and being able to have their questions, their concerns answered in those right ways. And again, I think it's been highlighted that there isn't really a single way. It is many ways, but I think it is helpful to have these chat ideas, have thoughts, because it's by doing those, by using that multi-pronged attack is not the right word, but multi-pronged approach, and thinking of new ways, new spaces to vaccinate, new ways to have those conversations, and really to work with the community to really help address some of that information and reach to help them to answer the questions and therefore have the vaccine in the way that they would like to have them.
Penny Tuff has raised the question of engagement champions from the community, and who might be able to be of assistance of training and selecting engagement champions within the community. Is that and it's been successful in some areas? Is that the case? Is that something that's actually happening? Getting training up of locals to do that. And the question about funding as well for this. I'm been around long enough to remember the whooping cough episode. And the whooping cough episodes, as I recall, I may have got one or two details wrong. There was a health visitor who got vaccination rates up and got prizes nationally for her efforts, and was made redundant shortly after she was awarded the prize. I mean, what are we doing about that kind of, are we training people up? And isn't that one of the key issues Les Sternberg highlighted in about the training of carers in his letter to the Times? Training of carers can't be neglected in this whole scene. The same thing, the training of health visitors who are familiar with the community and go out into the community was one of his suggestions. So, anybody care to comment on that?
I think absolutely in terms of community champions, and during COVID, we are, and certainly I'm giving a London-centric approach, and I know there's similar approaches wider than just London, but there was a whole London community champion programme across communities, working with boroughs across the capital. That was really successful. And I think what was important about it was that two-way exchange with those community champions. So both using the community champions to deliver messages into the community, and they could reach ways that traditional health systems aren't able to do so, but also that other way of exchange of information back. So we could pose questions and say, how does the community want to be reached? What are the key issues for them? And therefore influence policy making in that way. I think you posed a really key question, is what happens with funding and how we can sustain that. And I think one of the things in terms of COVID legacy is realizing the importance of community engagement and how we sustain that in effective ways long term. I think for the specific polio campaign that you've talked about, it is, as you say, more than just the champions. It's also some of that training. So we're working very closely with the NHS to do training for health visitors, for example, for community nurses, for different settings, to have that conversations, to enable partners to feel confident. And again, it would be useful to know within the Jewish community where we can have most effect in those spaces. I think one of the ideas that partners came up is there was a lot during COVID of using Jewish women within the community to vaccinate for COVID. Do we want to do something similar for polio and use Jewish women vaccinators, for example? And if community champions from the community want to ask about polio, how do we then give them the space to answer those questions so that they feel confident in answering that in the communities that they have as well?
Right. I mean, it's but the question is the funding for that going to come centrally to the community, or is the funding going to come from within the community? Have to fight for its share of the local ICS or ICB budget? How's that going to work? Mary, do you know the answer to that? Or
well, I think one of the problems in this space is that the organisation of immunisation services has changed in terms of responsibilities on several occasions. And even if you get a sustainable model put in, the next structure comes along and decides, oh, well, maybe that's something we can get rid of. So I think there's an issue with resource in general, but there is a bigger issue with keeping things that work in place. And I think Ben used the word about 100 times, sustainability. Leonora's used it again. It's a word I keep using because I think doing one-off interventions will only have limited action, of course, impact. So I do think that. I mean, my understanding is that there is a proposal that immunisation will probably be led at ICB level rather than nationally, and clearly the localism argument is all about having tailored services at a local level and not to have a national, model. So in a way, you can't have it both ways. I mean, you've either got to have responsibility and resource matched at a local level to what the locality thinks it needs, rather than saying we need more national funding, because I think that's why we suffer this sort of on-off approach. And I think this community we've known has specialist services that have then been pulled, and that doesn't help. That doesn't engender trust in the long term either, does it?
There's one other question before everybody disappears. The question about swimming pools is raised in Nemesis, and Jonathan, is there anything known about mikvaot and spread of I don't think it appears in Nemesis, but anybody else want to comment about the question of swimming pools and mikvahot and so on? Should they be closed because of danger of polio? Anybody?
So I'm not aware of anything specific. I don't think they should be closed, but perhaps those who are there, it's a great opportunity to talk to people about getting their kids vaccinated.
Because in COVID, of course, there was, as Dr. Spitzer and I will remember, there was huge pressure about the question of spread in mikvahot, and it, sure that it's an enterovirus rather than a respiratory virus this time around, so it's more likely. I think that the time is looming late, and I think some people are connected to Israel as well. So I think we're already way near tomorrow there, and also we've really got our money's worth, more than our money's worth out of you. So I'd like to call on Fiona to propose a vote of thanks. And Fiona's there.
Yes, good evening, everybody. I've been obviously listening avidly and trying not to ask questions. I've been holding back. But thank you for inviting me. I'm just going to say thank you to all of you. I'm not going to pick out anybody because I think that would be completely the wrong thing to do. But it's been a really lively discussion. Thank you all for your presentations. And actually the Q&A has been really lively too. So that's been great fun to keep an eye on. And thanks very much for all of you for putting answers in there, and people have been answering each other as well, which is even better. I just wanted to add, if I may, I mean, somebody mentioned the mikveh. I'm always on the lookout. My background in public health, some of you will know that. Some of you go back a long way with. The mikveh lady is a great opportunity to be a health champion. So if you haven't thought of that, I think never mind that the water isn't chlorinated. The mikveh lady is kind of potentially part of your matriarchal health champion society. So just throw that in as somebody else has brought up the mikveh. Sustainability funding. So the last couple of years, volunteerism has become a huge thing in the UK, much bigger than we ever thought it would be. I haven't really heard much about that this evening. I very much picked up a lot of volunteerism at the deep dive that Leonora convened last week. So building on that and building on generosity within the community, I think is something that would be worth thinking about. The other thing I just wanted to ask really is, given the campaign now in London and this phase that you're in of, what was the word you used? Discovery phase. Who should people come to? Because some people have been really bold putting some things in the Q&A, and we know that at these sessions, some people don't come forward, but have possibly got either brilliant ideas of their own or suggestions that they want to contribute to the delivery. They want to bring forward ideas about doing better. They might even know about sources of funding that the authorities don't know about. Is it Leonora they should get in touch with? And if it is, I'm going to shut up and just say thank you. It's been a really brilliant session, and invite Leonora to share your contact details with everybody here before we say goodnight. Thanks very much, everybody.
Thanks so much, Fiona. That would be brilliant. And as I said, we do want to hear ideas. There's really great ideas in the chat. I'm really happy for people to get in touch with me and our wider team. Working very closely with a lot of the panelists on the call and some people on the call and beyond, but it does build on the workshop we had last Thursday. So it'd be good to be in touch, and we can tell you how we use those ideas and build on them as well. So I'll pop my email in the chat, but David, very, very happy for you to circulate that as well.
Thank you. Thank you very much. And thank everybody. And really hugely appreciated the effort made by everybody to participate and to do preparations and to be engaged with with the audience, and with enormously, of course, with the subject. Good night.